Hello, my name is Bob Stenberg, and I'm going to teach you the basics of OB ultrasound in 15 minutes. So here we go. There are my objectives. I have no disclosures. And we're going to start off with one of the most important points, which is, the driver of a lot of our guidelines. And that is in the ER, when we're doing first trimester ultrasound, a lot of times we're worried about ruling out an ectopic pregnancy. And the way that you rule out an ectopic pregnancy is by ruling in an intrauterine pregnancy. And again, you rule in the IUP, which effectively rules out an ectopic. How does that work and why does that work? And that works because in the general population, the chance of having a heterotopic pregnancy, which is where you have an IUP and an ectopic pregnancy, is insanely low, well within our risk tolerance. And the one time of that is not the cases with IVF. So when you're going to be doing these ultrasounds, the patient can pretty much sneeze wrong and be first trimester pregnant, and you're going to do an ultrasound. This is especially a lot more helpful if they have yet to have a pregnancy ultrasound done during this gestation. And this is the way you should think about this. If someone says that they have undergone IVF, you are going to say that and you're going to call OB. And that in this scenario, it's just too high risk for us to really be doing these ultrasounds. You can do a quick fast just to make sure you don't see a bunch of free fluid, which will make you a lot more concerned. And quick note on the discriminatory zone, the bottom line is you should not use this to determine whether or not you do the ultrasound. If you think they need ultrasound, do it. The way that this is helpful is that it's helpful with, when and what kind of follow-up they need, and also kind of just figuring out the odds. The way that you think about this is there an IUP or not? And the way in the ER that we decide whether or not that they have an IUP is if they have a gestational sac and a yolk sac. An IUP in the ER first trimester is seeing a gestational sac and a yolk sac. So you need to find the bubbles. Quick anatomy review. When you're looking for fluid, the fluid that you care, the most common places you really want to try to look with your eyes is in that vesicouterine pouch and then that pouchodouglas, that rectouterine recess there. And that's obviously, a sagittal view there. So this is the most common thing that, most shops will be doing transabdominal ultrasound. In this scenario, it's ideal to have someone of a bladder left, even though a lot of times people already pee to get the urine pregnancy. But ideally, you'll use that bladder as an acoustic window to see the uterus and reproductive parts. Transvaginal ultrasound, it is really not as scary as you think. And one big thing that you can really kind of do to improve its success is by kind of treating the setup like a pelvic examination. That really kind of help you get the angles that you need to get. Because half the problem is trying to find the uterus. And sometimes if they're not in the correct position, it can be really challenging to do so. And usually you're kind of starting with kind of getting a sagittal view. And when you're holding the probe there, you're going to have thumbs up to have, that's going to be your indicator. And then to get your coronal view, which will look like that, you're going to rotate 90 degrees counterclockwise to get that view. Here is an image of a normal non-pregnant uterus. You can see nice consistent architecture throughout the uterus with a thin endometrial stripe. Here is a sagittal view of an IUP. And in general, when you're doing these scans, you're going to find the uterus, find the endometrial stripe, and try to find an IUP, which is a gestational sac and a yolk sac. So uterus, endometrial lining, there is gestational sac and a fetal pole and a yolk sac there. Wanted to go over quick anatomy that you will also be seeing. You will be seeing ovaries. You'll be looking for ovaries, and these look like chocolate chips from all those follicles. So you try to find the chocolate chip cookies, and those are the ovaries. And the other thing too is that these things flop all over the place. So expect them to be, anterior, posterior. They're not just always tucked in perfectly in that kind of right and left pelvic recesses. One quick point is, one thing that you have to have on differential if someone is having lower pelvic pain is you can't forget about ovarian torsion. So if you see a huge ovarian cyst, don't forget that pregnant patients can still get torsion. So don't forget that. Fibroids that have these, prominent, different echogenic appearance, and you'll see those quite often. This freaked me out when I first started doing these. These are the arcuate vessels. The uterus has a lot of blood flow to it, and in a lot of the images, it's kind of like bags of worms running along the side of the uterus. So if you see something that looks like a bag of worm, you're not sure where it is, throw color on it, and that will help you. Here's an image showing a normal IUP with those arcuate vessels on those lateral sides. Something else that you'll see quite commonly is called a Nabothian cyst. Those are the small, simple, hypoechoic structures that often cervically displaced around that cervix, which you can also see on that pelvic exam. This is a fan through where you see those Nabothian cysts. We're going to go through the quick progression of the early stages of gestation. With ultrasound, the first thing you see is a gestational sac. It is very important to recall that this does not mean that you have an IUP. And it's further important to note that you can have an ectopic and have something called a pseudo-gestational sac, which has to do with just hormonal changes producing that. So do not call this an IUP. Next, you'll see that double sigil sign. That is not an IUP. Next, you'll see a yolk sac. This is the first sign that you will see that you can definitively say that the patient has an IUP, assuming that this is in the uterus. This is fanning through. There you see that gestational sac and yolk sac. It's in the uterus. You're done. Gestational sac, yolk sac. Nice position in that uterus. Bun in the oven. You're done. There is progressing forward, fetal pole, and then you start getting, your embryo, and then you start getting your cardiac flicker as demonstrated here. Quick comment on getting the fetal heart rate. Using Doppler is a higher energy than using M mode. You want to use M mode to kind of correlate with that as low as reasonably achievable principle, a law principle, to minimize any effects on a very fragile creature. So what you will be doing is using M mode or motion mode. So you're going to find baby, find the heart moving. You're going to hit M mode. You're going to put that beam right through that heart flickering. You're going to find that correlating area. So you kind of see that hypocook gestational sac on both sides of that little embryo. And then you're going to find the flickering bouncing spot. And depending on what your machine's using 1 or 2 cycles to get that fetal heart rate. Again, you're not using Doppler for this. It is good if they're far enough along to document fetal movement, just to kind of demonstrate this is a reassuring ultrasound. So, high yield steps, when you're trying to document a good trimester ultrasound, things to say, you want to show that there's an IUP, you want to show it's a gestational sac, you want to show it's a yolk sac, and that they're not receiving IVF. And you want to get at least 1 fan through the uterus to make sure you don't see any free fluid, capturing heart rate and capturing movement. That's how you do it. One way you want to speed up your ultrasound, we like to go fast. There is a case. One thing that you can do is often we're using the curvilinear probe, and sometimes you can't see the yolk sac. So you can sometimes use a higher frequency linear probe as a means to see that yolk sac. This is the same patient showing the difference between the curvilinear versus the linear probe. In one study, 1 out of 3 patients they could not see on the curvilinear probe, they could actually correctly identify an IUP with the linear probe. So 1 out of 3 times it's saving you from having to switch to, a transvaginal ultrasound or setting up the OB. Now moving on to pathology, there is a case that sure sounds like an ectopic, and guess what? It is. There's your workup on the left side. Here we have a sagittal view. We have a transvaginal ultrasound. We have our bladder up top there. We have free fluid there. We're looking through the uterus. So we find the uterus. We find endometrial stripe. We do not see an IUP. We see a bunch of free fluid. We're getting pretty worried. We have a complex adnexal mass in this area, and this was an ectopic. Another example of an ectopic. So there's ovary there. We see a bunch of free fluid. We have uterus here. We look at endometrial stripe. We do not see an IUP there. When we kind of look off to that adnexa, we see an ectopic right along that adnexa there. So another ectopic, kind of that little gummy bear appearance of that uterus there, and then ectopic and that adnexa on that side. This is kind of one thing is you don't always see this perfect little gummy bear like this. Sometimes you only see free fluid, sometimes you see an echogenic mass, but the more fluid plus echogenic mass you see, the more concerned you are for an ectopic in the setting of a positive pregnancy test. These are examples of showing those ectopics with pseudo-gestational sacs. How do you feel about this image? Would you reassure discharge this person? Do you see a yolk sac? I don't see a yolk sac there. Oh, there's an ectopic. So gestational sac. Okay, this was a near miss that was picked up by OB. This was an ER ultrasound. They thought that this was a miscarriage, but you see a bunch of free fluid here posteriorly. We look in here, we see uterus, we see an endometrial stripe, we don't see anything in there. And as you look right in here, you will see an ectopic pregnancy. So if they have a positive pregnancy test and you don't see anything along the endometrial stripe and you see free fluid, you should be quite worried about an ectopic. This is a patient that I saw. It was a person that had a known ectopic and bounced back with worsening abdominal pain, some tachycardia. We immediately brought in ultrasound, and we saw this in the right quadrant. What should you do next? So positive free fluid right there. You should call OB. Why does this matter? And why do a lot of times do OB ultrasounds include right quadrant image? And that's because if someone has an ectopic and they have free fluid in the right quadrant, it is very likely that they will need operative intervention. Just kind of speaking to a larger volume of fluid and probably having more hemodynamic compromise. This was a great done by one of our ER docs. So this is at a freestanding ER. We're not getting the greatest images here, right? We're working through a decent amount of subcutaneous tissue. And what we see, oh, there's bladder there. Oh, is that a second bladder? That's a bunch of free fluid there. You can see we just can't quite make out clear enough whether or not there's an IUP there, but we have someone with abdominal pain, positive pregnancy, and some free fluid. Next step, what do? They went up to the right quadrant. They came right up to that liver tip. They saw free fluid at that liver tip, called OB, transferred right to OB, went to the OR, had a tubal pregnancy, which was managed. What about this image? IVF, abdominal pain, pounding into your head again. IVF, worry about heterotopic, make someone else do the ultrasound, maybe rule out free fluid. What would you tell this pregnant mother? Well, I don't know if you can really reassure someone about twins, but otherwise it looks like an IUP. What about this image? Uterus, gestational sac, yolk sac, IUP. good. What about this case? So uterus here, endometrial stripe, don't really see anything there. Free fluid, yes, we see free fluid all around there. And then what do we see over here? I see gestational sac and a yolk sac. That is not in the uterus. That's not good. What would you say to this person? This lady actually looked awful. She was pale as a ghost and in frank hemorrhagic shock. And we're seeing this weird, abnormal echogenic mass that in the uterus is way up there, right? So things aren't adding up. And when you really kind of focus in on this, when you focus in on this abnormal area, especially in this image, if you follow that endometrial stripe all the way down, this is actually contiguous with that endometrial stripe. So this person was having hemorrhagic shock from an active miscarriage and had to go to the OR. This is another example of someone that showed with abdominal cramping and vaginal bleeding with a positive pregnancy test. Transabdominal ultrasound was done, and what we see is this kind of fluid collection, again, along that endometrial stripe in that uterus, but it looks like it's contiguous with that endometrial lining down near that cervical region with the bladder right there. The speculum exam was done after this and showed products kind of coming out of the cervical os. And after review with OB, they decided to take her up to their cervix and remove with forceps. So this was, again, an active miscarriage, more stable. But the other thing that you do have to be considerate of is there is also something called a cervical ectopic. So just be mindful of that too. And again, there's no significant free fluid in that prior image. What about this image? So we see here, we have uterus, we found uterus, we found endometrial stripe, there's endometrial stripe there, but what the heck is that? So we have endometrial stripe, and then we have a gestational sac and a yolk sac that is in the uterus, but is not in that endometrial stripe. What the heck is this? This is an interstitial pregnancy or interstitial ectopic. There's all sorts of crazy nomenclature. You kind of don't care, and it's kind of a mess. But the bottom line is that you can't always say that there's a bun in the oven. One other thing that you really have to consider doing is you also have to look and say, okay, I found what looks like a pregnancy that's inside the uterus. I need to make sure it's in the endometrial lining and that it has sufficient amount of myometrium around it. Because what happens is it's implanted incorrectly into that uterine wall. And the dangerous thing about that is that they rupture later in pregnancy and they're more likely to die when they do. So how are we going to figure this out? What we'll see here is we'll see that uterus, we'll see the endometrial lining, and then we'll see, a pregnancy not in the right spot. And then we'll also see that interstitial line sign. So we actually see a line kind of connecting the endometrial stripe to the abnormal pregnancy. That's one thing that's quite specific. And then you're also really kind of looking at that, how much myometrium is surrounding that pregnancy. And here's kind of one example of measuring that. People, debate whether or not you're including kind of that, that surrounding, reaction there. But the bottom line is, there's different ranges, but if that myometrium mantle is less than 5 millimeters, you need to call OB. So there, again, uterus, pregnancy, really thin wall there, that's an interstitial. Uterus there, still kind of in that uterine wall there, really thin myometrium mantle, that's an interstitial. What about this patient? We have a bunch of, perhaps, a cluster of grapes right here with a really high quant. That is a molar pregnancy. You're going to add a TSH and talk to OB for this. What the heck is going on here? We have someone that just passed some blood and tissue, and now they're having abdominal pain and fever with a positive pregnancy test. Found uterus, found endometrial lining, but what the heck is going on there? We have all these hyperechoic foci with some dirty shadowing behind that. Man, that looks like gas, and it is. This is a septic abortion. So here, uterus, we see gestational sac, yolk sac, embryo. That looks good. Well, what the heck is going on over here? What's this hyperechoic lining with shadowing kind of right along that pregnancy? Well, that is an IUD. So you can call this what you want to call this, but this is an IUD with an IUP. What about this case? Largely asymptomatic. We have a really full bladder. We have a uterus on that cranial side there. We have uterus. We have a gestational sac. We have a yolk sac. We have a cardiac flicker there. When we kind of scroll down, we find that, and we have a normal fetal heart rate. There we have a myometrium mantle that is quite sufficient, and that was my little dude. So everything went okay there. Here's a bunch of high yield numbers if you want to refer back to. Quick highlights: you want to have a gestational sac and a yolk sac and not be undergoing IVF. Take a look at that mantle and make sure it looks adequate. And to try to speed up your ultrasound, if you can't quite see that yolk sac, with the transabdominal, consider linear probe if the patient is thin enough. And if you have an ectopic patient with fluid in the upper quadrant, they very, very likely need to go to the OR. This is an awesome book that Bob Jones put together. So use that QR code, and that's a free book you can get with your phone. And we can just kind of go through some questions and other points along the way. Thank you so much for your time.